All right, everyone. So I think we're going to get started now. People seem to have all shown up that are going to be showing up tonight. So first off, welcome you guys. Thanks for coming out, especially on this Monday of a long weekend. I really do appreciate you guys taking some time out of your limited time off to come hang out with us. So this is part of our Monday night training series that's put on by Division 176 here in Victoria, BC. My name is David. I'm one of the assistant officers in the training division here. Just a couple of housekeeping things that we're going to mention right off the bat. During the presentation itself, everybody is going to be muted, except for me. So if you do have questions about whatever I'm talking about on the screen there, we just ask that you put them into the chat line that you see over there, and we'll be picking up the questions. We'll probably stop a couple times to make sure everybody has a chance to get their questions answered. We're going to try and keep answers to the questions limited mostly to myself. We've had some issues with past events of some less than accurate answers being given into the chat. We just want to try and prevent that. We do have a few people here that I know happen to be subject matter experts, especially for some of the scuba diving parts of it. So we may end up deferring to them for a few questions along the way. But generally speaking, you put your questions in the chat group and we'll answer them as we go. Otherwise, these are being recorded. They'll be posted online for you to be able to review typically by tomorrow morning is what we're aiming for. So with that, I'm going to mute everybody and turn off your ability to unmute yourselves. We're going to get started. So tonight we're going to be talking about drowning and near drowning, and we'll be touching on scuba diving injuries a little bit. For those of you who don't know me, my name is David Brown. I'm a paramedic and a dispatcher with the ambulance service here in British Columbia. Outside of work, I've got a particular interest in wilderness and remote medicine, as well as some nerdy stuff that doesn't particularly matter here. Some standard disclaimers we're mentioning with most of these. So none of the things that we're going to be talking about tonight reflect any of the practice updates that have been circulated around COVID-19. If you're at a division that is still operational, you should be referring to whatever your DS has sent out as being the most up-to-date set of clinical guidelines. And none of this, but all the principles here are going to be remaining after this whole thing's blown over and we get back to it. Further on, St. John Ambulance does not participate in water rescues. We do not do rescue activities, anything like that. So just be conscious of that. And this topic really is going to be focused around what we do after being presented with a patient that's been removed from the water. Outside of St. John Ambulance, do use extreme caution if you're off duty and you see somebody actively drowning in the water. We'll touch on that a little bit later. And then just the obvious follow-ups too. I'm not a physician. I am not a scuba diver. I'm not an expert in any of these topics, but this is based on evidence, science, and research that we've been done, as well as past practice and experience. Then just following up on this as well, before I became a paramedic, I did work as a lifeguard, which is where some of the biggest surprises for me in this presentation have come, because the updates from when I did my lifeguard training nearly 10 years ago to now, it's sort of the most up-to-date evidence-based medicine. A lot has updated. So some of the things we're going to be checking or touching on tonight. So we're going to be talking about what is drowning. It's actually a remarkably complex question. A little bit of epidemiology around drowning, because it's something I find fascinating. We're going to talk about dealing with cardiac arrest as a result of drowning. We are going to very briefly touch on some very gentle anatomy and physiology of the lungs, because that's going to set us up for the next section. We're going to discuss the difference between saltwater and freshwater drowning and near drowning. We're going to talk about treatment of near drowning, and we are going to touch on scuba-related emergencies towards the end, although that's more of an interest point than anything. So we'll get started. So our first topic is, what is drowning? So there's quite a bit of discussion about what constitutes drowning, but the American Heart Association, which is the most sort of definitive organization I've found, uses that it's a process resulting in primary respiratory impairment from submersion or immersion in a liquid medium. And that was given by a Dr. Utstein. I'm almost certainly mispronouncing that. But Dr. Utstein, back in the late 1970s and early 80s, created one of the largest and first registries tracking cardiac arrest from drowning. as well as exploring treatment and outcomes from that. And as part of that, he had to be able to have a clear definition of drowning that everybody worked with. And the definition that he made has been updated a few times, but generally speaking, has led most of the research that's been happening around drowning and using his definitions forward. There are some controversies around terminology. Near drowning is what a lot of people recognize, and there's been quite a bit of discussion that suggests that's actually an inaccurate term that shouldn't be used. And most of the rest of this presentation will be using the term non-fatal drowning to explore the idea of drowning that doesn't result in a cardiac arrest. So that's just a point of clarification as well. Non-fatal drowning in this case is not considered a cardiac arrest that gets a return of circulation, but a drowning that never caused cardiac arrest in the first place. So just a little PSA coming from when I was lifeguarding. This is just generally very important information. The typical idea of somebody drowning with their arms waving above them, screaming out for help, is quite inaccurate. And it's been what's been promoted in popular media since time pretty much started. But it's really not particularly true to what we'll see in these patients. So most drowning patients aren't able to call out, and actually the base physiological response is that their arms will come in, and it's very unlikely, given that they're using their arms to try and get themselves up out of the water, and that they will almost certainly not be able to wave out for help. Drowning patients do not instinctively kick to keep themselves up above water. Their heads will be going just above and below the water. They'll be working very hard just to keep themselves at that point. And a lot of the time you'll see them sort of, it looks like dogpaddling, but essentially climbing the invisible ladder, just clawing at the water, trying to pull themselves up and above the water. So it's just a useful piece of information to remember if you're out at the lake. There's some fantastic YouTube videos out there if you want to end up on a watch list, but some of the near drowning compilation videos on YouTube are actually really fascinating to get a better idea of what that behavior looks like, because it's not at all what we typically sort of expect it to see. And again, just as a really huge thing, somebody that is drowning, if you get in the water to help them without training, experience, and the right equipment, they will drown you and then drown themselves again anyway. It's something to be extremely cautious of. And if it's not something you have training and experience in, it's something I would be very cautious of doing. So who drowns? So there's some huge numbers out there, but everyone seems to agree that drowning is about the third leading cause of death worldwide. And that's from the World Health Organization. In 2014, they published their global paper on drowning worldwide, and it's huge numbers, particularly into the lower and middle income countries. And those numbers are even reflected in Canada and the US, that lower income individuals are significantly more likely to experience death by drowning. But this was just a number that really surprised me. But in Bangladesh, 43% of deaths in children come from drowning. Now, these numbers are actually suspected to be significantly lower than the true numbers. A lot of the time in the US, so somebody that falls off a boat and then drowns, a lot of the time their death is considered to be a boating accident instead of drowning, or an industrial accident where somebody falls into a pool of water with all their equipment on, might be considered an industrial accident or a fall. So these numbers are believed actually to be significantly higher than reported. In Canada, we have about 300 deaths per year. The Life Saving Society in Canada are the ones that do the most tracking of drowning. But that said, they experience the exact same issues there. And a lot of their numbers are actually coming from tracking the media and social media occurrences and articles that way, because there's such poor reporting of drowning deaths in Canada. We thought this topic would be especially particular now, just because we are getting right into that 4-month period where 2/3 of drowning happen in the 1/3 of the year. So the summer is obviously a much more dangerous time. Similarly, adults 65 and older are actually the highest age group risk for drowning, or for death by drowning. And a lot of that just comes into that is a larger age group that's being tracked compared to most of the other populations. But that also reflects accidental at-home drownings, so bathtubs, that sort of thing. as well as being out in lakes, ponds, oceans, that sort of thing. And then that is obviously followed by the more expected category of young adults, and particularly young men between 20 and 34. So our initial considerations when we're presented with a patient just been pulled out of the water, right off the bat, it's scene safety. So considering our water hazards, considering the people around you, making sure you are clear. So if it means that someone's been pulled out onto a dock, it's probably going to be safest to bring a patient right off the dock onto dry land, so you have that safe and clear room to work. From there, you do want to consider your mechanism of injury. So if someone has been cliff jumping or diving into the water, you do want to consider a C-spine injury. But that said, it's not something that we should be taking on a routine basis. Watson's article actually found that only 0.5% of the patients that they were able to find documentation of had any kind of C-spine injury after drowning. And all 11 of those patients had a significant mechanism attached. So either some kind of motor vehicle incident that led them into the water or diving that way. And then we're going to do a very quick ABC check to really make sure that we know right off the bat if this patient is in cardiac arrest. So our treatment of cardiac arrest patients is largely going to be the same as what we do in our normal practices, just with a few considerations. So typically, patients that have been pulled out of the water have experienced a hypoxic cardiac arrest, essentially suffocation, because at the very final stages of drowning, your instincts give up and you actually just inhale or aspirate a very large amount of water, and your body just isn't able to get any oxygen. And that leads to problems with the heart, problems with the brain, problem with everything there. So quick considerations are, you want to make sure that your patient is moved into a dry area. So a patient pulled out onto a beach, if they're in the very wet sand there, or at a pool, for example, if a patient's still in that wet area right next to the pool, you want to make sure you move them into a dry area, both for provider safety. There is the theoretical risk that when you defibrillate, somebody could get shocked through the water there. But also too, your defibrillation isn't actually providing nearly the same level of electricity that's required if some of that's being sapped off by the water that the patient's laying in. And with a similar goal, we want to make sure we're drying the patient off before we defibrillate. So just give them a quick wipe with a towel. Obviously, they don't have to be bone dry, but making sure at the very least the area in between the pads on the patient is dried off. And it's just going to make sure your defibrillation is the most effective. In a hypoxic cardiac arrest, the key problem is that the patient does not have oxygen. So these patients are not actually likely to be in a cardiac rhythm that's going to fix the cardiac arrest with electrical shocks through defibrillation. The key issue is that they don't have enough oxygen traveling through the body. So a big goal in our management of this cardiac arrest is going to make sure that we're getting maximum oxygenation to these patients. And we're going to consider that. We're going to go over a little bit. We do also want to make sure we consider alternate causes. So just because someone has come out of the water doesn't mean that they have drowned. We had a case in town here quite recently of someone who was pulled out of the water after their boat caught fire, who was found to be in cardiac arrest, but it was a very low likelihood of them drowning. Similarly, we do quite a few triathlons in Victoria. It's entirely possible that someone can just have a cardiac event during that very intense swim. And again, for these patients, if you're working at a higher level of care that's involved in transporting these cardiac arrests, definitely a patient that you should be considering an early transport on for a higher level of care. So just as a few reminders, Nav Chima did a much better discussion of this last week than I will in one slide. But that said, some high quality oxygenation tips are making sure that we have those two-person ventilations. So instead of one person trying to do both a CE grip and ventilating, you have one provider whose whole role is just to hold the mask onto the face, either using that V grip or that we see in the picture, or the CE grip that's more commonly taught. High flow oxygen connected to your bag valve mask. So making sure that you have your oxygen tank absolutely wide open to make sure that every ounce of what you're putting into these patients is 100% oxygen. And again, just for people working at a higher level of care, these are absolutely patients that you should be considering a no desat and PEEP for when you're ventilating them. And Nick's also just chiming in that in Victoria in the past, we have cared for patients who've had their cardiac events during the swim portion of triathlons. So that's always something to keep in mind, is just because your immediate impression is that it might be a drowning because someone's pulled out of the water, doesn't mean that that's necessarily what's happened there. So again, while we're talking about these patients, we're going to talk a little bit about patients in cardiac arrest that have had also hypothermic, because these are a special subset of it. So patients are not dead until they're warm and dead. So that means a patient pulled out of the water, particularly patients who've been pulled out of the water cold, who've been in there for any extended period of time, are not dead until they've been warmed. And again, this is going to be a patient that is most likely going to end up in the emergency room. So patients that have been removed from a cooled water do have a better prognosis overall, because there's a possibility that the patient's brain had been cooled before going into cardiac arrest. In this case, our cutoff number is going to be 20 degrees for the water temperature. So technically above 20 degrees, it's not considered a hypothermic drowning event, whereas water below 20 degrees is considered a hypothermic drowning. For those from Victoria, though, just for reference, Thetis Lake barely gets above 20 degrees in the high summer. So the 20 degrees is actually a pretty high, quite warm body of water. And it's not something you can be able to test with your hands there. There's not a lot of great evidence to demonstrate exactly what timeline is considered unworkable for cardiac arrests. Every time you see someone say, yes, 1 hour is the timeline, someone else has a published case study of a patient that was underwater for 2 hours and then resuscitated and walked out of the hospital completely fine. Generally speaking, most agencies, including BC's Provincial Ambulance Service, use approximately 60 minutes in the water to be the tipping point. There is the exception there in very small children, because they have a much larger body surface area compared to the rest of them, or sorry, they're much higher body surface area to internal surface area. They cool very quickly and essentially have a much higher chance of being resuscitated in these cases. So our two big indications here are going to be people in very cold water who were cooled very quickly, and very small children. So really we're talking children below the age of 2 or 3. And beyond that, their proportions start to line up a little bit more. I'm just going to pause here quickly and ask if anyone has questions around specific to cardiac arrest and drowning. So no DSAT and PEEP. They're not issues I'm going to dig particularly deep into. No DSAT is essentially, in this case, just a very aggressive oxygenation. So it's adding a nasal cannula underneath whatever oxygenation tool you're using. So in this case, a bag valve mask with extremely high flow oxygen on it again. So that would be a nasal cannula easily with 15 to 20 liters per minute of oxygen going through it, just providing more airflow, more air pressure. And there's quite a bit going on there that is outside the scope of St. John Ambulance. And similarly, PEEP is positive end expiratory pressure. So it's a tool that's used on the bag valve mask. And essentially all it does is helps create a little bit of pressure inside the lungs all the time. And you'll see in just a few slides why that can be positive. But again, both of those are outside the St. John Ambulance MFR scope of practice, and not something that, if you don't understand, you need to be too worried about. But with submersion hypothermia, is there any need to bring the casualty out of the water supine to prevent hypotension? Sorry, so Andrew asked aside here, with submersion hypothermia, is there any truth to the need to bring the casualty out of the water supine to prevent hypotension? That's not a concept that I'm particularly familiar with. We'll talk about our general management of hypothermic patients that aren't in cardiac arrest a little later on. But certainly not that I'm aware of. If you've been trained to do that I'm assuming the forces, then I would continue to do that. But that's not something that I really know about. And Kyra just sent me a message saying that the Canadian Coast Guard does teach that. if they teach that, I'm guessing they're not doing that for no reason, but I don't know the background behind that or the supposed physiology behind it either. If anybody else has other questions here, I think we'll move on in just a second. I'm going to grab some water. Right. So this is where we get into the big brain nerdy stuff. We're going to talk very briefly about the lungs. So, and alveoli are the most important part. So what we're going to see here is a very very blown up part of a very small piece of the lungs. So as the bronchi come down, they break off into smaller bronchioles that spread throughout the lungs, and those bronchioles end in these alveolar sacs. And alveoli are the teeny tiniest part of the lungs, and you can see they're surrounded by these capillaries. And the alveoli are the part of the lungs that actually do the gas transfer in between the lungs and the bloodstream. And the alveoli are held open by essentially a magic goop called surfactant, and that just helps keep them all propped open. That's all we're going to do about the lungs. Any questions about that? Does that make sense with everybody? Excellent. So, saltwater versus freshwater drowning. This was one of the ones that actually really surprised me when I was doing my research. So previously, a lot of organizations taught that there was a huge difference between saltwater and freshwater drowning because the body has a process called osmosis. So it wants to keep the electrolytes on one side of a membrane the same as on the other side of a membrane. So the idea was that if the lungs were filled with fresh water, the fresh water was significantly had significantly fewer electrolytes in the lungs versus into the body. And so the body would actually move a lot of that fresh water into the bloodstream in an attempt to balance it out. However, it's actually been, and then the reverse would happen during saltwater drowning. So because there were so many more particles in the lungs than in the rest of the body would actually move plasma and other fluid from the body into the lungs, creating more fluid into the lungs. And it's actually been found that that takes a significant amount of fluid to be brought into the lungs before that's a concern. So in most near drownings, they really only are going to bring in about 3 to 4 mils per kg, and it requires 11 mils per kg fluid before you start to see that fluid shift occur. At more severe levels, so around 22 to 30 mils per kg of fluid that's been aspirated, the body will actually start moving electrolytes around, and that's when things can get very exciting and can cause some really interesting dysrhythmias that get quite confusing. So moving on to our first piece of terminology, it's going to be non-fatal drowning. So really in this case, again, it's quite a controversial discussion, but it's patients who were submerged or immersed in water who didn't die, typically with aspiration of fluid. A lot of other people want to see this also include a loss of consciousness, although in this case it doesn't, and the American Heart Association doesn't require a loss of consciousness for something to have been considered a non-fatal or near drowning. And we're going to dig into it more, but this is still a very serious medical emergency, and we'll talk a little bit about why. And a lot of the time it is going to be a 911 call for us at the St. John ambulance level, if nothing else, so these patients can be assessed by higher level of care providers and often will require transport to the emergency room. So in a non-fatal drowning, when someone's been removed from the water, they're still going to have aspirated quite a bit of liquid into their lungs. So aspiration is just inhaling. So the same way when you're drinking water and you start to cough it up because it goes down the wrong tube, it's exactly that, but on a much grander scale. So salt and fresh water, when they end up in the lungs after it's been aspirated, they wash out a lot of the surfactant all across the lungs. And because of that, the surfactant is what's actually keeping those alveoli open. And so because the surfactant collapses those, they're not able to exchange the gas. So that, and again, because there's so much less area available to exchange that gas, these patients will become significantly hypoxic. So their oxygen levels will be quite a bit lower, just because the amount of area that those lungs actually have to do their work is so low. So when we're presented with these patients, we've got a couple of key assessments we want to be doing. Vital signs, these patients should be considered to be unstable until they prove themselves otherwise. So we're going to be doing fairly recent serial vitals, and we're going to be watching carefully for trends. These patients will first begin to become short of breath. If you are working in a division that has care providers who are monitoring oxygen saturation, these patients will start to desaturate. And then again, as the whole progression happens, they will start to become hypoxic, hypotensive, shocky in general. Similarly, it's very important to be monitoring GCS and neurological vital signs here. Neurological impairment is likely going to be one of the first signs of hypoxia that you'll see in these patients, even before you'll start to see them desaturate or other methods that way. We are going to be auscultating the lungs, so we're going to listen very carefully across the whole lung field. Again, this is really going to be one of the times you want to make sure you're hitting all of your auscultation points across the front and back. You're really listening for those thick, coarse crackles and essentially goopy sounds that you'll hear, particularly in the basses. Just because you don't manage to auscultate something that sounds like fluid or pulmonary edema does not mean it's not present. So I just want to really reinforce that just because you can't hear anything does not mean that this patient has some aspirated water and isn't at risk for some of the ongoing problems that are there. And some of these patients need to be monitored for a while, especially if they're not going to be going to the hospital or going to be getting followed up by the triathlon medical clinic or being monitored at a level of care beyond. They need to be kept for about as long as you can hold on to them at your first aid post. So treatment, positioning. We want to keep these patients sitting, and we want to keep these patients sitting as straight up and down as possible. And I've made my high-tech visual aid here that is a water bottle filled with water. So we're going to imagine that this is somebody's lung. So right now, when they're sitting straight up and down, we can see that this water is just filling up the lower part. So it's just this surface area that's being restricted from exchanging oxygen because there's liquid in it. So all the alveoli in here are blocked off, so oxygen can't make it to them. And the concern is, as we start to lay these patients onto their back, you can see that this fluid all of a sudden starts covering a much greater surface area all across that patient's lungs, which is going to significantly impair their ability to breathe on their own because there's suddenly so much less surface area that's available to do gas exchange. This is consistent across a lot of patients with shortness of breath, especially some of our CHFers that do have that pulmonary edema building up, which is why it's almost universally better when anyone's having any respiratory distress to sit those patients up. Hope that makes sense as we're going. Any signs of respiratory distress should be treated immediately with high flow oxygen. So these are patients that even if they're having a little bit of trouble breathing, someone you might normally just put a cannula on and see how they do, these are patients that you should immediately be putting a non-rebreather mask at maximum flow on right away, because these patients do tend to decompensate quite rapidly if they're going to. That said, there's good evidence that patients who make it past about a 4 to 6 hour danger window are at a very low risk of decompensating. That's typically the time range that most emergency departments are going to keep patients from monitoring. And that is quite well evidence-based. There are some older teachings in other groups that taught positioning to try and drain people's lungs, so variations on the recovery position. There's a very entertaining book from I think about the 60s I found that actually has an image of somebody being suspended upside down by their legs to try and drain the fluid. That has been proven to be ineffective. So just keeping your patient positioned straight up or as close to straight up as they'll tolerate with high flow oxygen. And again, these are patients that should almost always be referred to a higher level of care if they have any symptoms whatsoever after this. So as we're treating hypothermic patients who have been involved in a near fatal drowning, it really is standard treatment for hypothermia, and all of these topics go just fine for anybody hypothermic, especially people removed from the water. We do tons of triathlons here in Victoria, and there's a range from 14 to 25 degrees, which is the legal temperature to wear your wetsuit in triathlons. Below 14-degree water temperature, they don't typically permit swims, or they are very shortened. But that's a huge range, and a lot of triathletes only own their one wetsuit that lands somewhere in the middle. So particularly if you're at an event with a cooler water temperature, you can easily see triathletes becoming hypothermic coming out of the water. And you can also easily see people falling in the lake if they're not prepared appropriately. So these are quite common patients, but it's largely common sense. We're going to dry the patient off. We're going to remove any wet clothing that they're wearing. So obviously if they're wearing a t-shirt and shorts, we're going to take that off. We're just going to do passive rewarming. So we're not going to be actively pointing heat guns at them and packing them with heat packs. We're just going to be doing passive rewarming, which means we're going to remove the patient from an environment. So this is a great patient that if you're working out of at a division that brings an ambulance along, bring your patient inside the ambulance and crank the heat. Wrap them up in blankets, just that really nice passive warming. So after this, we're going to be moving on to the scuba part of this. So are there any questions about drowning, non-fatal drowning, near drowning, water-related questions there? Take a quick pause, see if anybody has anything. All right. Well, I guess we are consistent enough here. So just give me one moment here. Okay. Oh. Don't think Nick was trying to tell us that. Yes, that's a great point from Nick as well. At the rowing club, we do quite a few regattas in February because that's a perfect time to be out on the lake. And falling into the lake in February is quite cold. So because of that, we've used hot showers at the rowing club. Lots of options that way. So I think we'll move forward into scuba injuries. I'm going to be really clear. This is not a topic that I have a depth of expertise on. And Nick, who's very helpful in our chat here, has quite a bit of experience as a very real dive medic. So I think we'll largely leave, like if you have questions, I'll happily defer to him because he's got much better expertise on this. So there's three most, I'm going to at least throw him right under the bus there and hope he knows. There's the three most common scuba injuries that we're going to be talking about here. Decompression illness or decompression sickness, which is the bends. If I was a real professional, I would have called it the same thing throughout the whole presentation, but clearly I haven't. Barotrauma and nitrogen narcosis. So decompression sickness, most commonly known as the bends, is the most common, I think, to me, the most serious condition here. So as you're scuba diving and as you're moving in general, your body absorbs gases coming out of your bloodstream. And as you decompress, so as you go further down, the water pressure is greater upon you. And so as you decompress and the pressure decreases, if you do that too quickly, the nitrogen that's in the regular gases you've been breathing in separates from that nice normal gas mix and comes out into itself and actually starts expanding as its own individual bubbles, both within the tissues and the bloodstream. So some of the very first signs of a presentation there are going to be just regular joint pain. But as it goes, these bubbles can cause obstruction of major blood vessels. They can cause embolism, they can cause embolisms throughout the body and some quite severe symptoms that way. They typically present about 15 minutes to 6 hours after surfacing. It can be presented with a significantly larger delay though, especially people flying home from their scuba trips. Because they're typically scuba diving at ocean level and then all of a sudden becoming decompressed as they go higher into the air that way. There's not any, because there's suddenly a lower pressure, these patients then can have those symptoms start again. So for us, symptoms of this, really, we're just gonna be providing maximal oxygen flow to try and assist it. Again, even patients that don't have respiratory symptoms here, would be treated with a high flow, with a maximal oxygenation. So that's going to be a non-rebreather mask right on to 15 liters per minute. And again, there is one definitive treatment for this, and that's a hyperbaric oxygen chamber. And these hyperbaric chambers provide air pressure 2 to 3 times greater than the sea level. So it significantly higher pressure. And that both helps, in this case, decrease the size of those nitrogen bubbles, as well as significantly increases the absorption of oxygen through the body. which helps move this nitrogen out of the body and into its system. In BC, the only public medical chamber is actually at Vancouver General, and we somewhat routinely fly people across the province to go there. And the hyperbaric chamber is also used as treatment commonly for carbon monoxide in emergent situations. And non-healing diabetic ulcers are a very common thing that they use the hyperbaric chamber for, which is not remotely relevant to this presentation, but I find very interesting. The Canadian Forces have a decompression chamber, or pardon me, a hyperbaric chamber here in Victoria that we don't have access to. So anybody with major CO or like a decompression sickness does end up getting flown to Vancouver General. And I've heard some interesting stories of some of our pilots, again, because the extra height and the lower pressure can cause an increase in symptoms here. These pilots find more creative, very low routes to fly, typically much lower than they would on a standard flight. So barotrauma is a result of unequal pressure inside and outside the body. So it's essentially the very extreme version of when you dive into the deep end of a pool, that pressure you feel around your ears. All you really have to do is just plug your nose and blow to increase the pressure inside your body there. But as people are diving deeper and deeper, that pressure on the outside increases and increases, and it's the same inside of the lungs. And so anytime that someone isn't equalizing their pressure, or in this case someone's ascending from a dive, if they're not actively breathing, if they continue to hold their breath up there, because the pressures become so unequal between the two, it can cause significant trauma. So eardrums or ruptured eardrums are the most common form of barotrauma, although it can come right up to ruptured lungs, which is a huge issue there. In terms of treatment, there's not very much we can do in this case. That's somebody that needs to be seen by an emergency physician and likely a specialist in the particular area that they've damaged there. So it's really just a patient we would be referring to medical aid. And then nitrogen narcosis, which is more just a point of interest, but high pressure nitrogen throughout the body causes a intoxicating, essentially an anesthetic effect. The rough guidelines I've been seeing here suggest that you can experience up to the equivalent of up to a standard drink per 33 feet. And so that's why especially divers diving deep mix other gases in instead of nitrogen. I think most commonly helium to try and avoid that. It's just treated by returning back up to the surface or going further or going higher up into the water, and almost immediately goes away. And Nick has some more thoughts about nitrogen narcosis he'd like to add in here. So I'll mute myself and unmute him to let him add in here.
Oh, there we go. It wouldn't let me unmute myself. The host had to do it. Hey guys, can everyone see me? Is my camera working properly? It's hard to tell. Oh, there it is. Yeah. Yeah. So with the nitrogen narcosis, narcosis is a really interesting thing because it affects individuals with a fair degree of variation. I hadn't actually heard the one standard drink per atmosphere, which is about 10 meters or 33 feet. This is probably not an unreasonable comparison, if you will. You know, certainly the effects can be really, really pronounced for some people. And I've certainly been on dives. Just to clarify, by the way, guys, before I start rambling on too much and scare a bunch of people, my background with diving and hyperbaric medicine is quite varied, but I did train and do quite a bit of diving, or do decompression diving up to about 290, 300 feet on trimix mixtures, helium, nitrogen, oxygen mixtures. And I did also train as a dive medic. It's a long story through the DDRC in Thailand at the Thai Naval Hospital. Again, long story, long time ago. But I do have a bit of a background in this stuff. Anyway, to talk a little bit about the narcosis, I mean, you know, I've certainly been on dives where I have been absolutely narked out of my head, completely impaired. And had a partner who was barely feeling the effects at all, and I've also been on similar dives where I've been absolutely fine, and I'll come back up and talk with my partner later, and they'll have said that they're really glad I was there because they were really, really quite impaired themselves. So there's a whole bunch of there's a very wide range of how people respond to the narcosis. It is a very fast resolving phenomenon. I wouldn't necessarily have even classified it as a dive injury, uh, rather than like a side effect of the physiology, if you will. It's certainly not harmful in and of itself, but it does have the potential to impair you while you're in a very dangerous and hazardous environment, and that can obviously cause some pretty significant problems if you become too impaired to be able to function safely on a dive, especially if you're doing a particularly deep dive, which is where you're likely to experience narcosis, can be a problem. For most people, even down to about 132 feet, which is four atmospheres or 40 meters, which is sort of the bottom limit of deep recreational diving. It's relatively easy for people to manage. Every now and then you run into someone who's particularly susceptible, but it's not going to hugely and drastically impair you within those depth ranges, at least. So I'll give it back to Dave. I don't know if you had any other questions you wanted me to talk about, Dave, or you're still muted, bud.
No, that's great. Thank you, Nick. So that's essentially the end of the presentation we have here. I'm just going to scroll through some of our references slides if anybody is particularly interested. This WHO global report on drowning is actually a fascinating read if you're looking for something more just exploring how drowning affects people differently all across the world. It's quite interesting, and I'd recommend giving it a read if you get the chance. This is our second page of references. ILCOR has published some really interesting recommendations around drowning. Again, just worth reading. So just the same reminders, this has been part of our presentation series here. We're going to be doing these every single Monday night Pacific time until the world sorts itself out. If someone gave you this link out of kindness and you're not already on our training list here, Anna is the person to email. She's our DS. So send her an email. And similarly, if you have other divisions that you're hoping to get in, or other divisions that you know that aren't getting this training, please feel free to have them get in contact with Anna and we'll bring them into the loop on that. We do also have some social media here at Div 176 that we're going to shamelessly use this chance to promote. And so please do follow us, and you can get an idea especially once we get back to our regular activities, the kinds of things we do here. I think it really helps us across divisions share different ideas. So at this point, we'll keep it open to questions from anybody who has them for a little bit longer here. I think we've got one or two that have come up. So one person says that when they worked in the South Pacific, the locals would take a drowned child, grab them by the ankles and spin them around using centrifugal movement to get most of the water out of the drowned child. And they claimed most survived. The short answer is, from what we've found, there is no real evidence to any of these positions that have that are going to remove the water. And at that point, really, the water is not actually the key point. It's the lack of oxygenation in that patient. Children are typically a little more resilient in hypoxic cardiac arrests. So to me, I would not be grabbing someone by their ankles to try and resuscitate them. I would be following our, as Nick says, this is not within our MFR scope. Don't try to use a spin cycle to resuscitate children. So there's no real evidence to support it, and there is much better evidence to other resuscitation techniques that I would be using. Yes, the SJA Victoria Twitter account is still alive, unless Nick has done something crazy in the last few days, but we put it on there because we'd like people to talk about. How much water are we talking to drown? Excellent question. I mean, you see all these ads about you can drown in 1 inch of water. SJA Vic BC, there we go. So the short answer for amounts of drowning is yes, you can drown in up to 1 inch of water. In the lungs, there isn't a firm number. Any amount of water aspirated into the lungs is considered a non-fatal drowning. It depends, I think, a lot more on the actual circumstances. So an average near non-fatal drowning typically has about, I think it was 3 to 4 mils per kilogram of regular body weight in the into the lungs, whereas fatal drownings are more associated with, I think, 11 or more mils per kilogram of fluid aspirated into the lungs. But that said, it is dependent. Somebody that aspirates that small amount of relatively small amount of fluid, but then but then spends an extended period of amount of water, spends an extended period amount of time in the water, could still drown. Largely fatal drownings are associated with somebody aspirating enough water that it's just causing so much hypoxia that they just aren't able to exchange gases anymore. So typically it's going to be a fairly substantial amount of water. And so that's where typically these near drownings are people who are just aspirating small amounts of water at a time. So they'll just get a mouthful here, a mouthful there, a mouthful here, a mouthful there, as they're still climbing that ladder. Whereas fatal drownings are really associated with some of the end stages as people run out of steam. As they start to go below the water, their brain essentially just causes an instinctive, huge gasping breath. And then when they're underwater, they're just aspirating almost a full lung full of water. For the complication after the fact, really any amount of water has the possibility to cause complications. There's also ongoing concerns about infection if someone's been breathing in lake water. There's all kinds of stuff in there that could easily cause pneumonia, which could then progress into being fatal or some other significant complications there. So that's why really any amount of aspiration, if a patient tells you they think they breathed in water, they should be going to a higher level of care for a further assessment, because that's not something that we can deal with here. Can you get narcosis above 33 feet? I don't believe so, but I'll leave that to Nick too. I'll just chime in here. Kyra, Nick, do you have a thought on that one?
Thanks, Dave. Sorry, just because I'm not the actual host of the meeting, I can't unmute myself. I can turn my video on, but I can't unmute myself. Someone getting narked above 33 feet would be pretty unlikely. You know, as an analogy, do you remember when you were kids and they had the little like liqueur chocolates, and everyone, when they were like 9 years old, thought they could get drunk by eating the little liqueur chocolates at the convenience store? The likelihood of getting narcosis above 33 feet is probably comparable to the likelihood of getting yourself intoxicated on alcohol by drinking liqueur or eating liqueur chocolates. I suppose there's a hypothetical someone might be hypersensitive to it. Never say never. I can't really imagine. Kyra's saying she gets buzzed on those now. Sure. I can't really imagine a scenario where that's a likely possibility. But as with anything in biology and medicine, I'm very reluctant to say never on anything. So that would be my thoughts on that. Back to you, Dave.
Thanks, Nick. We had another question message directly to me. If we are a current lifeguard, can we do water rescues on duty? And the answer is no. St. John Ambulance does not provide rescue activities, period. For the Victoria folks, there's a photo somewhere out there of me standing on a boat with a life jacket on, surrounded by marine search and rescue folks, which I got a slap on the wrist for. So we don't participate in rescue activities. We have the patient brought to us. Even on a St. John duty, we're not equipped. We're not able to do it safely. And frankly, we're not insured for it either. Does anybody else have any other questions from here? Well then, we have our why no DSAT. So the no DSAT essentially is just providing the highest possible level of oxygenation. So it's going to promote them becoming, that's just going to promote every ounce of gas that's being exchanged in and out of their body becoming 100% oxygen, which leads it to Sorry, so when every ounce of the oxygen, every ounce of the gas that they're exchanging is 100% oxygen, it just means the most oxygen possible is being sent through. So especially if someone has that fluid in their lungs, some of those alveoli are wiped out that way. Some of the alveoli have had the surfactant wiped out. If it means that 70% of the alveoli are all that's exchanging gas, that way those 70% are exchanging the most oxygen possible. Kyra, I think
throwing in there, Dave, really fast with the oxygenation, with the no DSAT and stuff. You talked a little bit about treatment for decompression illness, the bends. Without a deep dive into the physiology, which is probably beyond what we want to do tonight, by providing someone with the highest flow oxygen possible after a dive injury, you're actually increasing the osmotic pressure that's going to be pushing the nitrogen out of their bloodstream or out of their tissue and back into the atmosphere and purging the nitrogen a little bit faster. So, would on an otherwise conscious but possibly bent patient, no DSAT might be a little bit overkill, but that's part of the reason that high oxygenation potential is really favored in people with dive injury, and you probably wouldn't be completely out of line to consider it. At least I'd probably call a friend and ask them, but call a friend is code for call one of our online physicians to just discuss the treatment option with them. But it certainly wouldn't be an unreasonable thing to be thinking in someone with a dive injury as well.
Thanks, Nick. This is why we brought you along here. So if there aren't other questions coming up about the presentation tonight, in 2 weeks from now, we're very lucky, we're going to have an epidemiologist presenting to us around some of the basics of epidemiology and the science there. But they've also asked if anybody have questions ahead of time that they can try and prepare for in their presentation. So we're really hoping that if anybody has questions about epidemiology that they've always wanted to know the answer to, you can also put them into the chat here and we'll pass them along to our presenter. Also worth mentioning for next week, we're very lucky. We're going to have Dr. Sam Brophy, an emergency resident here in Victoria. He's going to be presenting around strokes and neurological emergencies, which is going to be a really exciting presentation to have.